Good day, I'm Andrew Solomon, a second-year internal medicine resident from the San Antonio Uniformed Services Medical Center, presenting a clinical vignette on CMV colitis for the 2021 Texas ACP. As a background for this case, it is important to gain appreciation for the rarity of active CMV colon infections. Despite seroprevalence rates approaching 100% in various regions worldwide, CMV typically demonstrates no initial symptoms and remains in the dormant state with normal immunity. Reduced T-cell immune function increases the latent reactivation of CMV and commonly leads to severe colon infections in the AIDS population and up to one-third of patients with severe ulcerative colitis. While CMV colitis elicits symptoms of abdominal pain, fever, diarrhea, and rectal bleeding, the findings of 6 or more bowel movements daily accompanied by at least one systemic sign of toxicity also define the true love and witch criteria for acute severe ulcerative colitis. When both these entities coexist, the question arises of whether CMV colitis represents a bystander marker of disease severity or an inciter of acute severe ulcerative colitis. We highlight an unusual case of severe ulcerative colitis with concomitant CMV infection in an individual who ultimately required a colectomy to determine the clinical impact of antiviral therapy for CMV and acute severe ulcerative colitis. Our case begins with a 29-year-old male diagnosed with ulcerative colitis in 2012 who was admitted for several weeks of abdominal cramping, diarrhea, and fever. His ulcerative colitis had been in remission with daily mesalamine and no long-term immunosuppression since his diagnosis. Laboratory evaluation was notable for leukocytosis, an elevated CRP, a positive enteropathogenic E. coli stool PCR. A CT scan showed thickening of his transverse colon with intra-abdominal adenopathy. A colonoscopy shortly after admission exhibited erythema and bleeding consistent with Mayo 3 disease. Initial endoscopic biopsies revealed chronic active colitis without granuloma, dysplasia, or malignancy. He was treated with a 3-day course of ciprofloxacin for enteropathogenic E. coli and an infusion with vedolizumab and salumedrol for severe ulcerative colitis. Infliximab rescue therapy was added for refractory disease. Failure of infliximab prompted a secondary review and staining of tissue from his admission colonoscopy. This identified CMV colitis with a serum CMV viral load of 1,100,000. He was started on IV ganciclovir and eventually transitioned to IV foscarnet for resolution of his CMV viral count to 194 prior to hospital discharge. Unfortunately, antiviral treatment did not prevent an urgent colectomy for definitive management of his colitis. With negligible short-term mortality, the management of acute severe ulcerative colitis should focus on avoiding the most feared complication, colectomy, which rises from a baseline of 12% to up to 40% in acute severe ulcerative colitis. From review of the literature, high-dose steroid use and endoscopic ulceration statistically correlate to increased risk of CMV colitis and acute severe ulcerative colitis. Yet, many studies document no difference in severity of disease or colectomy rates between CMV positive and CMV negative patients with acute severe ulcerative colitis, even if antivirals are used in the CMV positive cohort. Still, current guidelines recommend colon endoscopy within 24 hours of admission to identify CMV colitis, which can be targeted with antivirals, ganciclovir, valganciclovir, or foscarnet for a therapeutic response of 50 to 80%. Ultimately, our case demonstrates the important correlation between steroid-refractory ulcerative colitis and CMV colitis, which can be missed without early colon endoscopy and proper use of specific serologic studies or tissue immunohistochemical staining. The data on whether CMV serves as an indolent marker of disease or clinically relevant pathogen requiring treatment in severe ulcerative colitis remains conflicting. Delay in CMV diagnosis and thus antiviral treatment, especially with significant viremia, may contribute to the added morbidity of colectomy in acute severe ulcerative colitis, as in our case.